So good evening, everyone. So myself, Dr. Karthik, I'm practicing currently in Trinivali in Kidney Care Center. So today I'm going to discuss a case about catheter dysfunction. So basically, this is a case of 75 years old who's on maintenance hemodialysis for almost 5 to 6 years, and also with multiple access failures. Almost all the access has been exhausted with both RC fistulas are primary failures, and BC right BC was a secondary failure, and almost transposition was attempted. And left side we attempted a AV graft, which got failed because of the graft thrombosis. Then we went ahead with the right tunnel catheter for a while. Then it was blocked, it was removed. And so the only option was us to salvage this access, which is in the left IJV and tunnel catheter. So this patient, after multiple attempts of catheter dysfunction, we tried a reticulase lock for 3 to 4 times, and it worked well for some time. Then again, he presented with catheter dysfunction. So we went ahead with the contrast study in this patient. So initially, this is the first contrast study. As you can see, there was hardly any flow, and there was a delayed filling of the contrast in the catheter tip also. So what we did was, we went ahead with passing a guide wire through the catheter, and which was unsuccessful. We manipulated at the tip of the catheter, but still we could not pass the guide wire beyond this point. So what we did was we removed the catheter. Since we manipulated, we thought like we'll do one more contrast study, and this contrast study showed a clear picture of fibrin sheath, at the tip of the catheter. So then the first picture you can see we pull the catheter cranially, we almost towards the clavicle side, and we pass the guide wire. So the guide wire passed freely after pulling the catheter up. Then we did a contrast study. Then, as you can see, the fibrin sheath was extending till the till the almost to the catheter tip and then near the clavicle. So along the full length of the catheter, there was a fibrin sheath actually. So we almost pull the catheter up, and so since we want to avoid the same track of fibrin sheath, we want to create a new access. I mean, not the access, cannulation site. So we went ahead with the left IJV, again a new cannulation site, and we did a contrast study. We can see a multiple collaterals, and there was hardly any flow in that site. So we were left with no option. Instead, maintaining the same tunneling and same cathedral site actually. So this was the new cannulation site with the contrast study, which showed a complete collaterals and blocked the left IJV. Then, so what we did was we passed 8 balloon, assuming that 14.5 French tunnel catheter is almost equal to 4.8 So almost double the size of the lumen diameter. We passed a 8 balloon, and we did a angioplasty. Balloon dilation, as you can see in the tip of the, trying to disrupt the fibrin sheath actually. Then after multiple attempts, we did it in a multiple sites also. Then we went ahead with the serial dilation. We went ahead with the upsize balloon, 12 balloon. And so one interesting thing we noted during this dilation was the patient was complaining of a pain, which we didn't expect, because we were not expecting any stenosis at this point. We were expecting only fibrin sheath and straightforward disrupting the fibrin sheath and securing a new catheter. But as we dilated with the 12 balloon, the patient was complaining of pain. So we thought there might be a clinical stenosis in the venous part. So this balloon dilation might help both, disrupting the fibrin sheath as well as the dilating the venous stenosis. So we went ahead with the 12 dilation, balloon dilation. Then, So after the dilating with 12 balloon, we secured a new catheter through the same guide wire over the same guide wire, and we went with the contrast study. As you can see, there was a clean flow, there was no fibrin sheath, and yeah, the flow was restored actually. So how can we prevent this kind of fibrin sheath? Is there any options for managing the fibrin sheath, whether with the balloon rupture or snaring method or any clot repair system or using any drug eluting catheters? So yeah.
Yeah, thank you, Karthik.
Yeah.
So actually, this is the case which I had written in that book by Dr. Kashi. This man absolutely had, say, both femorals. I know he had long time. This was all done outside. He came to me for an access creation 4 years back with all the possibilities closed. So this with this as the index case only, I wrote that chapter. Both the AVF, both the BCF, shunts, and both femorals, both jugulars. But somehow we managed to do a left TC, and that pulled on for 4 years. And in between, he repeatedly came for blockage, and we sort of came out with reticulase block and all. And this,
And the motor juice.
pardon? Yeah. So that is the, I mean, balloon, I mean, fibrin sheaths and disrupting with balloon is not a big deal. But here we had no other option than to use the same tunnel, I mean, same pathway. So we may have to go through the same sheath, but we managed to rupture the lower end. And another thing, we wanted to know what balloon size we should use. 12 we used here, and which gave a lot of pain in the chest, which scared us. So we thought there should have been additional stenosis in the vein. And yeah, so that's what we wanted to share with the audience. The balloon size we can go up to while trying to rupture the sheath. And also any other methods which like snaring and what others prefer. And also we came across that, Karthik, what is that? Retriever, not retriever.
Which one?
You showed on
This one, clot repair system.
for
Clot repair system.
faculty from US might come across that. I saw it in the net only. So any other method to disrupt the sheath? And these are the things we wanted the audience to discuss. Yes.
Sir?
So, Bala,
Yes.
So there are, and in this, I mean, not in this scenario, generally, the first thing is balloon dilation and or resighting the catheter. If balloon dilation has to be sequential, it has to be from innominate vein down to the atrium, because the length of the fibrin sheath, we don't know how big is the length of the sheath. The second one is a snaring. Snaring, if the femoral veins are good, normally we try to come from the opposite side, snare the catheter and try to strip it off. It will be very hard. In this scenario, I think you mentioned there's no femoral veins, if I'm not wrong.
Yes.
So what we would have done is, if once the wire access is into the atrium, we would have used the snare over that wire. We would have crossed the fibrin sheath, opened the snare, and then strip it upward. Sir, I'll call you back in a second, sir. My fire alarm.
Oh.
So, Bala, it's
Yes.
a very common problem that we encounter with the catheter dysfunction and the fibrin sheaths. The only difference are a couple of things. Anytime we do a procedure, I always want to ask, why am I doing? What is the objective of the procedure, right? So if you are having a patient who is catheter dependent, then your intention is to provide a space at the tip of the catheter for it to flow, right? Now, if we are going to replace it with another catheter, then whether you have a associated stenosis or not, it's immaterial, because if you go and you treat the venous stenosis with 12 millimeter or 14 millimeter, it doesn't matter. If you leave the catheter in that spot, that stenosis is going to come right back. Okay, it will not stay open. So all that we did was we took additional risk and the risk to the patient of a potential vein injury, right? So in my mind, if I'm having a patient with tunnel catheter whose flow is not working well and the dysfunction is due to a fibrin sheath, my aim is to do the fibrin sheath disruption if I can. The fibrin sheaths can be very elastic, to be honest with you. Even though the catheter is only 4.5 millimeters and you're using 8, you feel like you're getting 100% thing and it should rupture. In my experience, not all fibrin sheath will rupture at that, and you might need a bigger balloon. I do agree with the previous comment that what we do is we advance the wire into the IVC, get the balloon, a deflated balloon, down to the right atrium or slightly below that, wherever the previous catheter tip was, fully inflate, and then gently tug it back over the wire. Then what happens is the fibrin sheath is now caught behind a dilated balloon. And as you're pulling it back, it comes with it. And if there is a stenosis, you will feel that resistance. At the point of resistance, I partially deflate the balloon, bring the resistance into the middle of the balloon and reinflate it. So two things happens. The fibrin sheath, which was caught behind the balloon, is now, along with the narrowing or the stenosis underlying, will now be able to disrupt to an 8 millimeter or 10 millimeter, whichever balloon you used. And then I've sequentially, from that point onwards, sequentially I dilate all the way up to the venous entry side. When we do the exchange, when we put a new catheter in, from the point of venous entry site, I do an angiogram to see what was going on in the whole vein. And only after that, I would choose whether I want to treat the underlying venous stenosis to an appropriate size or not. And that decision is purely based upon, am I going to plan for another permanent access like an arteriovenous fistular graft on the same side? Because if it's not, then I don't want to take additional risk of rupturing using a 14 millimeter balloon. So I would rather just leave the catheter as long as the catheter flows well and good. But if you ever remove the catheter out, then you might lose the whole vein. I do have a different point of view about when you see a fibrin sheath, putting a needle into the vein and trying to put another catheter, because the fibrin sheath has no natural defenses. So the body will not be able to fight the fibrin sheath. If you remove the catheter, the fibrin sheath just stays within the lumen. In fact, it causes partial blockages of the lumen, and that's how you potentially lose the entire true lumen, and the true lumen will just wrap around the fibrin sheath, and the false lumen of the fibrin sheath becomes the vein, and which is nothing but your stenosis. So 2 points, I would definitely not treat all venous stenosis to its maximum diameter at the time of catheter exchange unless I'm following that up with a permanent access creation. And as far as the use of snare, there has been instances where, despite of using 3 times the size of a catheter, the fibrin sheath does not rupture or disrupt at all. In such situations, we have our partners go in and strip it down. A big word of caution: people have gotten into a lot of trouble because when you snare anything, you cannot control what you're catching. So if there was any associated stenosis, when you're snaring it down, you could tear the vein. So if you're using the snare only at the tip of the catheter and then pulling it down, that's fair. You have enough leeway for that. But if you're going all the way beyond that curve, I would be extremely careful about it.
And yes, you said dilate the balloon at the tip of the sheath and you pull it up. So
Correct.
you retract the catheter fully outside and having only the guide wires.
Correct.
And then you can we pull the whole sheath outside of the body?
So, okay, let me reframe
Okay,
thing.
yeah,
The way I do is first get your wire down, dissect your cuff out. As you're pulling back, you inject the dye. Once you figure out that there is a sheath, you take that entire catheter out, the old catheter out, only the guide wire is in, through the sheath all the way into the IVC, load a balloon on top of the wire, get the balloon down further than the tip of the previous catheter, inflate it, and gently pull back over the wire, make sure that the wire is secured still. And wherever you're feeling resistance, you deflate it and reinflate, and then try to pull back. I get my balloon almost semi inflated balloon out through the tunnel. So anything which was caught behind the balloon gets retracted out of the body. The wire stays. I would never want to lose my wire. And then once the balloon is out, then we load a new catheter on to the old wire, get it into the vein, the tip into the vein, and then do an angio. So most of the time, the tip will be in the innominate vein, and then we do an angio to make sure that nothing has happened and what's the true lumen looking like. If the true lumen is all very deceased, that's when I stage my decision based upon what am I going to do after this.
Lal, see, keeping in mind that this was a left-sided catheter, and if I pull out the fibrin sheath, with the balloon size maybe 10 we would have used, right? If not 12.
Right.
And if the 10 size balloon comes out of the vein, the venotomy becomes so big, and your next catheter may not seal it. So
correct. So you don't take out. You don't pull through the fully inflated balloon. Once you reach the innominates, you start to make it a partially inflated. Okay, so the partially inflated balloon will not stretch anything. It just pulls the contrast through, and you will still have enough resistance for the fibrin sheath that it comes out with the balloon. Yes, you won't fully pull a 10 millimeter balloon through the venous venotomy side, but because it won't allow you, so you will end up releasing some of the pressure from the balloon and then retracting it. So it will be a partially inflated balloon that you bring out.
The sheath will wrinkle. It won't come as a cast, right? It will wrinkle at the end of the balloon. So when you try to come out through the tunnel, and I think that maybe you may get it stuck in the tunnel or halfway. Nothing happens.
No, as long as the sheath is behind the balloon, it just comes smooth out. It's like a sleeve of your shirt. It just pulls you throughout.
Okay. Anybody else? Do they have such experience of pulling out the sheath through the puncture site itself?
May I, sir?
Yeah.
So regarding that snare, I think I agree with this, sir. It is difficult, not or easy to do snaring, and obviously you can just snare at the tip of the catheter. You cannot go way beyond, because sometimes you may not be able to go beyond very much deep into the vein. I generally keep it for the right side only, because it's straight. Because snare, you don't have guiding things, because you cannot guide snare the way we guide the wires and the balloons. So snare, I will keep it into for the right side and for the straight catheters. And regarding, we have recently had one discussion on the WhatsApp. Someone has used Fogarty over the wire for a vibration disruption. So that works out well, because the balloon is very short length, and the balloon is not very long, and it's cost effective also compared to what the normally we use for a balloon, because Fogarty, inflated Fogarty, you can pull it back, and again, as we all know, it may not damage the vein what the normal balloon does. So I think inflated Fogarty is another way of looking at the disrupting fibrin sheet. I'm yet to try this inflated Fogarty for this particular cases. So I would like to understand from others also the use of inflated Fogarty over the wire for the fibrin sheet disruption.